Hi, I'm Ed Pavlik in Lexington, Kentucky.
And I'm Frank Lawton from London, UK.
We're here with GYN Garage, and we're going to talk about a paper today, which is on the topical imiquad versus surgery for vulvar intraepithelial neoplasia, a multi-center randomized phase 3 non-inferiority trial that was published in Lancet in May of 2020. And this is a very interesting and informative paper. It's a non-inferiority trial. Frank, what do you think?
Yes, it is important, I think. Imiquad has, we all know that it has activity as an immunomodulator against a number of epidermal skin conditions. And it has been shown in numerous phase 2 studies against placebos or other immunomodulators that it has an activity. This is the first paper, they say, and I think they're absolutely right, where it's actually a randomized trial looking at against surgery. So I think it's an important paper from that point of view. They essentially looked at VIN, vulval intraepithelial neoplasia grades 2, 3, the usual ones, the HPV associated ones rather than non-HPV, and compared self-administration of imiquad versus surgery. The problem, well, there are a number of problems, but one, it took 6.5 years in 6 centers in Austria to recruit 110 patients. Now, the population of Austria is about 9.5, 10 million. The population of London is about the same. And I can't believe that it would take 6.5 years to recruit 110 patients with VIN 2 to 3 in London. So I think there's some sort of bias in the recruitment of these patients from the 6 centers. However, that's the case. I think looking at what they've tried to achieve and looking at the statistics, I think it works very well. Essentially, it was a self-administration of imiquad for about 16 weeks, 3 times a week, with a further of another 4 weeks if it didn't work, versus excision or laser therapy. So in the end, the CR rates, the rates of complete clinical remission, presumably based on vulvoscopy, were 80% with the imiquad group and 79% in the surgical group, which I think is probably fairly reasonable. Interestingly, the number of patients, there was an 18% dropout in the topical treatment based on a switch to surgery, loss to follow-up, pregnancy, etc. So an 18% dropout is pretty high for a treatment regimen. I think the more important problem, I think, with this study, and it was very well randomized for age, smoking, HPV status, etc., previous, etc. There were 5 patients in the surgical arm with invasive vulval cancer, 1A, 1B, but vulval cancer, and there were none in the imiquad arm, which makes me think that there's some sort of bias here. Why was there such a difference in the invasive cancer regimen? All these patients who've been biopsied, why were there nearly 10% in the surgical arm versus 0% in the topical arm, which sounds to me like some sort of biopsy bias, which clearly will affect the problem, affect the outcome. The other thing is that the side effects that this case reported were, it's difficult to read it from, but possibly 20 or 25% G2, G3 side effects, whereas other studies have shown much higher side effect rates. 17% patients stop treatment with topical treatments because of the side effects. So I'm very concerned that they've either underdone the side effects, or underrepresented or underrecorded the side effects, or for some other reason. the other thing is that the complete response rate, which they've reported, is 80%, but a meta-analysis, which they do report in the study, has shown only 53%. So they've got a very much bigger complete response rate with the imimiquad compared with other studies. And also, the thing that I think they should have actually said was, if it is really true that a number of patients in the topical treatment probably had cancer, based on the fact that nearly 10% in the surgical arm did, then have they possibly cured or improved the response rates in the early cancers in the imimiquad group? And that's something else. I mean, the next study, I assume, should be something along those lines. The other problem, of course, is that it's self-treatment. You can always, do patients really do what you say they do? Do they apply the topical treatment as necessary? Do they do it regularly every night? Do they do it 3 times a week? Sorry. Do they do it for 20 weeks or whatever? But I think it's an interesting study, and I think probably this might be the beginning of a ablatory or surgical approach to the management of VIN 2 to 3. And I think that's why it's important.
Sure, yeah, I agree with you. I will make a comment though about the length of the study. We got to remember that the pandemic was in the mix there, and that may have affected a little bit of it being drawn out in time. I think though the question you raised about, well, why didn't they say anything about the fact that the therapy from Aldera was better with regard to frank malignancy? That there were none in that case, while there were 5 in the surgical group. And it's possible, despite the sort of variability in self-application, that this drug, in terms of inducing fevers, activating cytokines, and all that, goes to wider fields than the surgical and a wide excision, might achieve. So that's a possibility. And as you pointed out, that is really probably the future of a lot of things. But it's the future of this drug right now in terms of, a serious illness, not just a basal cell or acidic keratosis treatment on the scalp or on the forehead. To me, what struck me was really, really nice is they had the wise position of looking at it both from an intent to treat standpoint as well as a protocol driven standpoint.
Yes.
And basically they're showing you, look, if everybody didn't do everything in an intent to treat standpoint, here's what you get, and here's what you get if you really do it the right way on a protocol driven. And I think that's to their credit. And so that's good. It's really basically moving back the curtains and letting us see how it is either way. Go ahead.
I think a very honest paper. I think you're absolutely right. They said there were problems with recruitment. Even say that one of the problems in their conclusion is that it took 6.5 years to recruit all these patients. I think they've been extremely honest, and for that reason, it's a very good paper, and it opens up so many more possibilities for topical treatment for VIN 2-3, or even, frankly, for a T1 vulval cancer. This is good stuff.
I'm guessing that one of the reasons they didn't say more about how effective the treatment was against invasion was the referee stopped them, slapped their hands, and said, "You can't say that."
Oh yeah, you could be right. Well, I hope they've got the courage and the clinical nous to say, okay, let's do the next study and let's look at early invasive disease. There's no question. I think that's good.
Well, absolutely. That's another version of GYN Garage. It's good to see you, Frank.
Take care, my friend.
Look forward to seeing you again. Take care.
Bye now. Bye.
Bye-bye.